Welcome to Trial Site News Podcast Series. Today on our episode, we'll be talking about rural research initiatives and the impact COVID-19 has had on bringing advanced research to rural communities. Now, to do this, we have Dr. Kedar, who specializes in autoimmune diseases that affects the musculoskeletal system, such as rheumatism, arthritis, and other disorders of the joints, muscles, and ligaments. So, Dr. Kedar, welcome.
Thank you.
Now, before we jump into the COVID-19 situation, how did you make your way out to St. Lawrence?
Sure. So St. Lawrence County is the largest county in the state of New York. It's a very rural and it's a poor county. The way I made my way out here, I've always been interested in rural health, and I'm an East Coaster. I went to medical school in California. I worked out west for 20 years, actually. And after residency, I had been a general internist for several years in Washington State. And I got very comfortable doing a mixture of inpatient and outpatient internal medicine. And when I went through my rheumatology fellowship, I continued to do a lot of internal medicine moonlighting work. So when I left fellowship, I still was a functioning general internist. And a few years into practice as a rheumatologist, I really wanted to bring back some of those general internal medicine skills. I wanted to be in a place where there was a shortage of subspecialists, where I needed to do more. And I knew that the only place where I could have a really broad footprint as a rheumatologist, where I could be a true generalized specialist, is the term I use. I could treat everything within the scope of rheumatology without having to share cases with a whole bunch of other subspecialists the way it's typically done in the city. I knew that would happen best in rural America. I also am from the East Coast, as I said, and I love the East as I love the West. And so when this opportunity presented itself to be the first rheumatologist in St. Lawrence County, I thought it sounded fantastic. And 6 years later, here I am still.
Now, let's shift then to COVID-19. Now, this pandemic has ravaged the nation. What have you found is the situation with COVID-19 in rural America?
So rural places are known to have sicker patients in general relative to non-rural places. They're known to be very negatively affected by a general shortage of physicians and a much less discussed, but really particularly severe shortage of subspecialists. And so the situation with COVID-19 in rural America has been one of under-resourcing, has been one of not having enough physicians, not having enough hospital beds, not having enough access to clinical trials, not having parity in general with non-rural places. It's been what we've seen with the COVID-19 pandemic in rural America is a compounding, an exacerbation of lots of long-standing problems, and it's really been a disaster. It's been a pandemic that's hit rural America with particular force. A lot has been written about this. I'm not by any means the first to mention it, but it's been a pandemic that has really, to use your term, Adrian, ravaged rural America in particular.
Now, from your experience, what would you say are the biggest challenges then facing rural health systems during this pandemic?
The challenges are challenges that have been years in the making. The challenges are those that come from having this lack of resources, not having enough physicians to treat COVID-19 patients. So, for example, in our system, on our COVID treatment team, we're a very small team because we don't have. Some of us have no backup at all, like myself. No one else on the team plays my particular role. So, as one example, between mid-September and mid-January, I took not a single day off. I worked every single day of the week on the COVID team, over 120 straight days, not a day off. It's a good example for you of what under-resourcing looks like. So even when there might be a resource, there might be just a small amount of that resource. In my example, it's me, a rheumatologist who also does interstitial lung disease work and who has served as a member of our COVID-19 treatment team. So that's one thing that's really hurt us in rural America. Another thing is that a lot of our public health departments are under-resourced. And so it's hard to have the resources to do all the contact tracing we need. A lot of our hospitals have closed or are losing money. And so to bring in expensive medications for COVID, like, for example, tocilizumab, which we used early in the pandemic and are now using again, the cost of that can be prohibitive for a small rural health system. These are very expensive medications. Clinical trial access has been a huge barrier that's created an opportunity gap for rural patients. There are very few rural health systems that have clinical trial departments. Ours is the very rare exception to that. Yes, there are some rural places where there are larger health systems that have a presence in the community, but that's not the same as having a non-academic, independent health system that has its own clinical research department. Much of rural America is served by small hospitals. Much of rural America has no hospital. We have a couple hundred rural counties that have not a single physician. And so that's been another big part of the resource problem, is not having research. So the challenge is one of a whole number of resources that we lack, which we have lacked for a long time. And what the pandemic has done is it's shined a light on how bad things have been, on how poorly rural health infrastructure has been developed in this country. And I've talked about how there are two Americas in medicine. And this pandemic has really shown us that. Rural medicine is really in a developing world state for much of rural America still. And you can see that in how rural America has done in the pandemic.
What do you think inhibits most the development of more clinical research then in rural health? Is it these two factors, or are there additional problems?
I think it's a variety of things. So for one, building clinical researchers takes training. Most people in internal medicine, in the internal medicine world who do research, not a perfect rule here, but most of them have subspecialty training, but the subspecialty world today tends to route people more towards being super specialists. So specialists in one particular disease, for example. Whereas what we need in rural America is just the opposite. We need generalized specialists, people who do everything within their field. So a lot of subspecialists don't go to rural America. That's just one of several reasons why they don't. Another is that there just is very little internal pressure within the subspecialty training world to push people to rural places. And so the people who would do research, such as medical subspecialists, often don't end up here. And you can see that in the very terrible subspecialty gap. There are, by some estimates, just 1/9 the number of subspecialists in rural places relative to non-rural places. That's one of the big reasons why we don't have as much clinical research infrastructure in rural places. Another is that small rural health systems often don't have the money to invest in those in research, because in the beginning there can be a bit of a financial loss before eventually clinical research departments break even or make a profit. And if you're a small rural hospital that's just trying to survive, you're not going to take a loss to build a clinical research department. It's just not practical. So it's a matter of the physicians having the training to do it. There's just a very small rural health research core in general in the country. Much of it is driven by non-clinicians. And there are very few clinician researchers who focus on rural health right now as a result.
Now, COVID-19, of course, has created a lot of change. Is there any promising possible signs that more research could come to rural health networks in the future?
I think so. I'll use our own health system as an example. We're funded by the Patient Centered Outcomes Research Institute. We have what's called an engagement grant we got several years ago to develop our local infrastructure for doing patient-centered outcomes research. We got an expansion of that grant for COVID-19. And we've just begun applying for larger grants as well to do practical rural health research, and in particular, patient-centered outcomes research. I'm hopeful that if our health system succeeds, we can serve as a template for other small rural health systems to do similar things and to develop research departments. I really would love to see in the future networks of different clinical, of different rural health research departments banding together to share data, to combine on big trials. That's done a lot in medicine now. If you look at the Patient-Centered Outcomes Research Institute, for example, they have a thing called PCORE-Net, and this is a network of networks, a group of different groups of different clinical trial centers that work together to pool data and to develop trials. I'd like to see something similar in rural places. I think that if we can get more attention with interviews like this one, it's just one example. If we can get more attention to what's going on in rural places, to how rough things have been, and then to the shining lights within rural America and what can be done. I think it can be done. It's going to require some real attention from our government, to be frank with you. They're going to have to make a national push, starting in Washington, D.C., to pay more attention to rural places and to back it up with not just language, but funding opportunities, training opportunities, programs. And I think ideally, they'll actually include people from rural America in those efforts. That's the only way it's going to be done well. I'm guardedly optimistic that it will happen based on our own success as a rural health research department these past 6 years and the last couple of years in particular. I can't say it's any guarantee. It's an uphill battle to bring attention to a cause that has been ignored always. But I'm guardedly optimistic, Adrian, that we will make inroads in the coming years.
Now, are there ways to leverage technology, say, such as telehealth, remote patient care, et cetera, to bring more research to rural communities and health networks?
Absolutely. We can leverage technology in various ways. So going off of research just for a moment, just to the clinic and to care delivery, we used a lot of we did a lot of telehealth in our health system, as did pretty much everybody in the country this past year because of COVID. And it is a way to deliver care to rural communities in a pinch. One of the big problems we have in rural America is broadband access. And this is also another issue I'm not bringing it up for the first time by any stretch. Everybody who follows rural matters is very well aware of this big problem. And one thing I found this last year was it was often a struggle for both me and a patient to both have a working internet connection that kept us on a video call, for 15, 20 minutes, all the duration of a call. But once we get better broadband access to rural America, I think telehealth will begin to play a more meaningful role in care delivery. Now, other forms of technology, there's a lot we're doing actually in my clinic for that. There are patient engagement pathways that can help you stay in touch with your patients and help prevent patients from falling through the cracks in rural places. There's a company called Twistle that I work with. They're based out of Seattle. It's excellent at developing patient care pathways like that, and that has a big interest in rural medicine. That's just one example. I think that machine learning will play a role in healthcare delivery in rural places as well, and machine learning / artificial intelligence, and that's a whole subject in and of itself, which I won't go into deeply here. So I think the best answer to your question, and I know it's a little bit of a long-winded answer, is that when you deliver care to a rural community, it's best if you do it as part of a network. And ideally, a patient is surrounded by a good network. They have a primary care physician. If they're a rheumatology patient, they have a rheumatologist. They have access to technology that helps them get care when they can't get to the clinic. Maybe their rheumatologist is 4 hours away, so they have a good working internet connection. They may have certain patient engagement tools that they can access through a cell phone to keep them on track with their care team and with their care goals. And so technology is going to be an essential part of any good rural care delivery network. And there are various ways, I think, in which that can be done. Now, as far as research goes, I think the next step is really to study how different forms of technology can be used to deliver healthcare. And that's actually an area of big interest for me. I can't give you details about it, but we are working on and have worked on several big ideas, grant ideas about how to use technology to better deliver care to rural communities. So for various reasons, I think technology can help us deliver better care to patients. I think it can interface well with research in the future in rural communities.
Now, what about NCI's NCORP? Did you find that to be a successful program?
Sure. I know that NCI has the community oncology research program. The idea behind that, which is a network that brings trials to communities, is a general idea that I think is great. And it goes back to that idea of PCORNet we were talking about before, with the Patient-Centered Outcomes Research Institute, this kind of idea of bringing trials into communities via a network of different sites that work together to do better research and to bring better opportunities to communities. I think NCORP is great. I'd love to see consortia or groups of rural health-focused research centers coming together to bring opportunities to rural communities and to do bigger studies to help better define the rural health landscape. In rheumatology, for example, there's almost no rural health research. And I was telling somebody just the other day that the cases I expected to see in rural America as a rheumatologist and the cases I ended up seeing were totally different from one another. And how that was a good example of how little we know about the rural rheumatology landscape. And to really know that landscape better, we're going to have things, rheumatology versions of NCORP, where we have sites coming together, pooling data, and learning more as a result. But absolutely, that's an inspiring example. And I think that we can work with models like that one, like with models like PCORNet, to bring good networks of rural health research sites to rural communities.
Now, before I let you go today, if you had a call to action for those who might be watching, what would you tell our viewers what they could do to help support rural health networks?
Talk to your local politicians. Talk to your congressmen, congresswomen, senators. Talk to President Biden. Tell them that they demand more attention for rural health research, for rural America in general. You know, it all starts with a concerted effort from the top to make things different. And the only way that's going to happen is for lots of voices to speak up I have a website you can look at later, Adrian. It's called www.ruralamericaandcovid19.com. The reason I bring it up right now is that I wrote a letter to, at that time, President-elect Biden and his COVID-19 advisory board, asking some questions and making some suggestions for how to improve the diversity of the board. There's nobody on the board from rural America. And it's very hard to see how they're going to craft a really good response to the pandemic in rural places without a single member of rural America on the board. But I never got a response. But if we had more people writing letters like that one, and you can find that letter on that website as just one example of something you can write to a politician. If we had more letters like that one, every person is going to write their own letter. The things that matter to that person will be what comes out in the letter. But if we had more people writing to their local and their regional and their national politicians, and if we had it as a movement almost, then we could really get stuff done. We could create the impetus to really fund the changes that need to happen in rural places.
Sounds like the right move to make. Well, Dr. Kedar, thank you so much for taking the time out of your day to speak with us. We know you got a busy schedule, and we greatly appreciate you taking the time.
Adrian, thank you. Take care.